Great. Thank you, Ann. Appreciate it. Appreciate the invitation, and hopefully we'll be relatively quick and efficient with our time, and try to have more time for some conversation and some questions. So, basically, what I want to talk about is just how we can master medical billing for what we're referring to as medically necessary oral care and surgery, for a number of different reasons. Number one, to improve access for patients. Number two, to advance medical dental integration. Number three, to drive and grow patient volume in our practices. And number four, to increase revenue. Many people think about medical billing and sort of understand the challenges and nuances associated with it, and a lot of times there's a significant amount of fear about pursuing medical billing for oral and maxillofacial procedures and surgical procedures. But the reality is it's easy to do if we understand the language, the coding, the nuances, and the like. So what I wanted to do is just talk about Nexus Bill, which is our complete solution that does both commercial and federal billing, and sort of introduce you to the idea of medical coverage for implant surgeries, talk about accurate coding and documentation, and how we can move towards that direction, what billing we can do for specific services, talk about a little bit about compliance, efficiency, and claims processing, the importance of interdisciplinary and interprofessional collaboration for billing success, and then really introducing you to Nexus Bill. So we define medically necessary oral care and medically necessary surgery as sort of two similar but distinct areas. Medically necessary oral care would be medical billing for temporomandibular disorders, facial pain, biopsies, things of that nature, obstructive sleep apnea. Where medically necessary oral surgery is really about getting reimbursed by Medicare, and the federal agency of Medicare for those over the age of 65 that are Medicare eligible, and or commercial insurances for the surgery necessary to do implants. So think about the all-on-X surgeries and the jaw and bone grafting that leads to that. It's important to understand, though, that Medicare, as we know, doesn't routinely cover dental procedures, right? So cleanings, fillings, extractions. However, it does cover medically necessary oral treatments. And there are some dental exclusions that have existed now for a year or so. We know clinicians are getting reimbursed for oral complications of cancer therapy, temporomandibular disorders, oral appliances for obstructive sleep apnea, pre-surgical evaluations for organ transplant and cardiac procedures. And there have long been clinicians. I'm an oral medicine clinician by training, dental school at UPenn, oral medicine residency at UPenn, and was there on faculty for many, many years, and have only billed medical insurance, both federal and commercial, have only used CPT codes and ICD-9 and 10 codes, and have never billed a dental code in my life, mostly because my practice was in orofacial pain and TMD, mucosal lesions, salivary gland disease, and dental sleep medicine. But what we have found is that Medicare will cover surgical treatments in preparation for and part of implant retained and supported prostheses. And that's really where Nexus Bill comes in. So this is sort of the world that I lived in as it relates to oral medicine coverage. And again, been doing this since 1997, only billing medical. What you may or may not know is that there are obviously different parts of Medicare, and each cover different aspects of healthcare. So Medicare Part A is hospital coverage. Medicare Part B is the medical insurance that covers outpatient services, including certain oral treatments tied to systemic conditions. Medicare Part C is Medicare Advantage, and we're getting reimbursed for Medicare with Medicare Advantage as well for some of these implant surgeries. And Medicare Part D, which is prescription drug coverage. The terminology may be new and foreign to some of us. You may hear things like PTANs, which is the Provider Transaction Access Number, or people refer to CMS, which is the Center for Medicaid and Medicare Services. We talk about ICD-10 codes, which is the diagnostic coding system that's used in medicine. CPT codes are used instead of CDT codes. There are clearinghouse claim scrubbing issues. There's Change Healthcare. All these different sort of terms and agencies and regulatory bodies play a role, including in claim adjudication with Medicare administrative contractors and their fee schedule, which is MAC. And those vary across different regions. And I'll actually show you some of the numbers actually from the New Jersey and Philadelphia area. So in order to become a Medicare provider and to bill Medicare, we have to enroll as such using PCOS, okay? And we have a couple of enrollment options. One is to be a participating provider that basically accepts Medicare approved fees and assignments, and then a non-participating provider, which individuals can charge about 115% of Medicare's allowable rate, but has to bill the patients directly. There are some specialists that choose an opt-out status, meaning that they don't bill Medicare and instead enter private payment agreements with Medicare payments with patients. So, you may be asking, why the heck would I ever want to go down the road of enrolling in Medicare and billing Medicare for implant surgeries? And we'll talk about that in a little bit, but I wanted to set the stage around our process and what that looks like at a 30,000-foot view. So the way Nexus Bill works is it's Medicare verification, eligibility, and coverage, working with the clinician to determine medical necessity and making sure there's proper documentation using our software, selecting appropriate ICD-10 and CPT codes, which the software does for you, claim submission with that supporting documentation, and then handling claim denials and appeals. All of that happens under the Nexus Bill process. This slide is very detailed, but what it does do is it does demonstrate that there are differences between medical billing in the federal space and medical billing in the commercial space. The bottom line is billing Medicare is easier because it's one consistent, identical process throughout versus the commercial side where there may be different rules in terms of coding, claim transmission, reimbursement basis, appeals processes, audit authorities on the commercial payer side. So Blue Cross may function differently than Aetna, which may function differently than United Healthcare. And so it becomes very, very challenging to work in the commercial space because of that variability. But what we do know is that in order for this process to be successful, there's a lot of learning that needs to go on if you want to do it on your own without a trusted partner like Nexus Dental Systems or a software system like Nexus Bill. You have to understand ICD-10 codes and how to use them, linking them to CPT procedural codes, making sure that we're using documentation best practices with our clinical notes, linking the oral health condition that we're diagnosing and treating to systemic conditions and comorbidities with appropriate x-rays and pathology reports and lab results and medical referral letters. And something that in 28 years of teaching in dental schools, I know we teach it, but then people go out and they become really bad and poor note writers. And so it requires a properly structured history and physical examination in the form of a SOAP note, which, again, our software does as opposed to a traditional handwritten or an electronically crafted note from A to Z. So again, if you're trying to do this individually or as an individual practice, there becomes an increased burden on the clinician and the staff to be appropriately trained and up to date, to make sure that they are getting the necessary pre-authorizations, submitting the claims electronically, tracking them, using the appropriate clearinghouses. Making sure the ICD-10 and CPT code combinations are accurate, making sure that the documentation is thorough and supports medical necessity, and that people in the office are staying updated on Medicare policies through CMS guidelines and MAC updates. And again, then there's always the risk of denials, and whether it be documentation or pre-auth issues or failure to demonstrate medical necessity, we know that it could be related to not using the right forms or tracking claims and following them up in a timely manner, or utilizing clearinghouses not to the level that they need to be used to improve claim tracking, and then having an understanding of the appeals process so that people within the office know understanding Medicare redetermination requests and strategies for effective appeals. It becomes burdensome for an individual practice or group of practices to take this on, which is why it becomes important to have the right partner like Nexus Dental Systems and the right software to make this seamless, to make it predictable, and to make it legal and defensible. And so that's really sort of where we come in and how Nexus Bill works. We auto-generate the correct ICD-10 codes and CPT codes. We craft using AI and your notes a clinical narrative that is medically appropriate and is compliant with medical billing, and creates those medical justifications and links of comorbidities to adverse oral sequela. So it really is a seamless solution for your team. It's automated. It's how we drive compliance because we have pre-built workflows. We have smart documentation prompts. We have claim tracking. And all of this is, in essence, offloaded from the office staff and the dentist and the professional, the clinician, to make sure that this is done in a very systematic way with people that have been doing it a long time. So why is this important? Well, I mentioned patient access, and we'll talk about that. More and more people are getting older, and the over 65 age group is the fastest growing segment of the population. They're maintaining their dentition longer, but they still have needs for tooth replacement. We know we're seeing advancing medical and dental health integration. And so what happens is patients that maybe historically have not been able to afford an all-on X treatment because the overall out-of-pocket cost was too much, now are saying yes to this because a portion of the surgery leading up to that procedure and outcome is covered under Medicare. And so there's increased case acceptance. There's improved patient outcomes on the medical side and overall health side. It allows for practices and DSOs to have a revenue cycle differentiator, and it allows for robust incremental growth in patient volume and in revenue. So again, I mentioned just the numbers of people. Right now, there are 65 million Americans over the age of 65. It's going to be 80 million in 5 years. As of right now or last year, almost 70 million Americans without dental insurance. 40% say they have limited or will have limited oral care due to their financial situation. 80% of patients know that they're delaying oral treatment will cost more money over time, but also that a majority of patients and a majority of oral health clinicians and dentists across the United States are unaware of the medical benefits for oral surgery procedures. By oral surgery procedures, I'm talking about implant and jaw bone augmentation and grafting procedures is there. But the connection has to be between what's going on in their oral cavity and the comorbidities that they have. Well, 45 million Medicare age patients have chronic illnesses, 80% with at least one, and 68% with two or more chronic conditions that are directly affecting their oral health. So these edentulous patients are at higher risk for advancing and increased medical costs and morbidity. So this becomes an opportunity for us as oral health professionals to make a difference. So who are we? What do we do? Nexus Dental Systems has been around for about 13 years doing medical billing. We have over 1,000 users of our Nexus Bill software. They're not all oral surgeons. In fact, a majority of them are not. Most of them are GPs, super GPs that do their own surgical implant placement. Anyone who's involved in implant rehabilitation surgeries, clinicians who do dental sleep medicine, oral medicine, oral pathology, temporomandibular disorders are using this software. What we do is fully credential the clinician and the practice with audit protection. On the implant side, we've been seeing reliable and predictable results, basically achieving consistent reimbursements of about $7,500 to $15,000 per case, depending if it's one arch or two arch through the appropriate medical necessity documentation. We have a Nexus billing portal, which simplifies documentation, billing workflows, reduces errors, makes submitting and tracking claims easy so people in the office don't have to worry about it. We have audit preparedness and protection built into the system and an audit defense team. We have comprehensive training and support with step-by-step training for staff and the clinicians, the dentists, with proper documentation and billing workflows. And there's a high return on investment, and I can share what that looks like. So just at a 30,000-foot view, I mean, basically there are sort of three phases to Nexus Bill. One is establishing the payer landscape for the clinician, the offices or groups of offices that we're working with, making sure everyone in there knows the process. And I use the word paperwork, even though it's completely digital, learning the appropriate terminology. Again, it's learning a new language. It's like moving from speaking French to speaking Russian. They're both okay, but you can't speak French to a person that only speaks Russian. And that's really the difference between the dental language encoding and the medical language encoding. We have an opportunity to work with the practices to build claims experience and a claim history, build an understanding of who pays out of network and who needs in-network access. We use under office NPI numbers. We have network activation that can be used. We can bill using our contracted rates. We have in-network with major payers and plans. We've demonstrated increased approvals. We have medical directors in all 50 states. We have compliance oversight and continued team coaching to optimize medical reimbursement. So, so what does this mean when a patient's in the chair? And that's, how is it going to disrupt my day-to-day operations with a patient that I'm working up for implant surgery and all on X? The answer is it doesn't. The screening, the intake, the consultation, the treatment plan all happen like it normally would. However, that consultation and that exam, we have a parallel system that is medical compliant history and physical examination documentation that needs to be completed, which would then create a customized letter of medical necessity with a customized treatment plan, appropriate ICD-10 codes linking to the appropriate treatment surgical codes, which would be CPT codes. And again, this would then be, after the surgeries, billed to Medicare and reimbursed. So how does this benefit us as clinicians and as the patients? Well, it's standardized, patent pending medical billing software for dentistry. We have proprietary end-to-end workflows and documentation that is all built into the system. We have seamless, comprehensive integration, training, and support for clinicians and staff. Offices are able to, in real time, track claim status. We have streamlined communication with various payers, both on the commercial and on the federal side. We've reduced claim denials and delays, and we've validated support in audit and in the clawback process. And so if you're not familiar with sort of the difference between how the feds work, the CMS works, and commercial insurance, basically, uh, if you're doing a procedure with Blue Cross and Blue Shield, there's a pre-authorization process that needs to happen for reimbursement. And sort of you have to go through the mindset of, and this may be a little austere, but guilty until proven innocent. Where on the Medicare side, you don't have to go through that process, and you are innocent until proven guilty. So as long as you've demonstrated medical necessity and your coding and documentation is appropriate, it is well within the rules of CMS. However, CMS does occasionally review their payments out to clinicians and will occasionally claw back a certain amount of dollars. We have built in a clawback defense, and I can talk about what that is. But I wanted to give you this is a practice that when we instituted Nexus Bill in this practice, they had two clinicians, and they were doing about $3.5 million in sort of regular. Neither of them are prosthodontists. They are both super GPs and did implants. What we did with them is we started to work with them and use Nexus Bill. They started with their Medicare reimbursements and got paid about 14 days from claim submission. We didn't have to go through pre-author denial process, right? Because it's Medicare, not commercial. We've had 98% success on our audits and clawbacks. What's been interesting is we've been able to track case conversion, and we're seeing 30 to 65%. In this office, it was this particular office that I'm talking about, it was closer to 65% case conversion with a 50% implant unit growth, a 200% growth on all on fours, 103% growth on locator fixed growth, and a 325% on overdenture growth. Again, because more patients are getting to yes, because now they're getting a certain portion of their overall global treatment covered by Medicare. And I had mentioned that these MACs by region, and this is just a for instance of New Jersey. We have these all in an Excel spreadsheet, so you can see New Jersey state. Like if we're doing a 21127, which is a jawbone surgery, bone graft, lower jaw, the MCR fee schedule payment is $43.87. Medicare's paying about $21.93. So again, is this as good as someone coming in and paying cash? No. However, it's better than a patient saying, I can't afford this at all, and I'm walking out the door and not doing this at all. And that's really the target audience, as we're seeing more and more patients over the age of 65 who don't have the financial means to do this. This gets them to yes more quickly. So what we do is training and onboarding, credentialing for the clinician. We have expert customer success specialists that will work with your team and you. We have a coding team. We have a billing and claims team. We have medical directors, as I mentioned, physicians in all 50 states, and we have a compliant and audit response team. So brass tacks. This has changed a little bit, and so I apologize if perhaps if you get online and look at this and it's a little differently. than what I'm presenting. But there's an initial investment, and sort of how this works is subscription service. There's a credentialing one-time cost, there's a training one-time cost, and a software fee, which is recurring annually. The billing services is 22% of revenue. It seems high. It's actually 17% of revenue, and 5% of the revenue goes into escrow as audit defense in the case of clawback. The estimated revenue per arch, based on our experience, is about $7,500. Doing cases 12 a month, the monthly revenue production on that would be 90,000. The annual revenue production would be over $1 million. And so if you look at $1 million times 22%, you'd be paying about 38,000 plus the $2,400 software fee to get that. Now, let's look at the profit analysis. 1 million in annual gross profit before the investment of 2,400 is 840,000. And then if you look at first year net profit after the initial investment, it's about 826. So when you calculate the return on the investment with net profit over initial investment, you're looking at a significant 5,200% ROI. So the initial investment and the monthly net profit, taking that into consideration, that break-even point is about a quarter of a month. So within 2 weeks, 1 week to 2 weeks, practices are breaking even because of the increased volume that they're seeing. So if you want to learn more, there's a QR code that you can scan. There's also contact information for what we do. I'm Scott Rossi. I'm our Chief Strategy Officer at Nexus and Serendipity Partners. But I'm happy to share this potential opportunity to increase your revenue and increase patient access with your implant patients.
Scott, can you display your QR code again?
Oh yeah, sorry.
Sorry, we were all in the midst of snagging it.
Yeah, let me.
And
I got a little overzealous, didn't I?
No worries. We appreciate the efficiency. Yeah, I think everybody's just digesting right now, Dr. Rossi.
It's a lot. It is definitely a lot. And again, the goal wasn't necessarily to convince you all to do this. It's just to let you know that this is available. It's certainly something that's growing, and the patient population that is going to need the implant supported prostheses that we're talking about are the ones that are growing at the fastest rate and have Medicare as their primary medical insurance. And so again, this is something that may be worthwhile to think about now. It may be, we've had individuals, honestly, that said, I don't want to do this in my practice. I have enough patients that are paying for this right now. I don't need to do more. What's interesting was we've also had practices who have taken this on where the more senior person has not done it, but the more junior person, an associate, has done it. And we've actually compared the growth of their practice. It's amazing how many people of Medicare age, once they realize in a community that there's a clinician that is taking Medicare and helping, and that's helping fund their implant surgeries, that they are becoming quite productive and outproducing their senior partner.
And can you hear me okay?
Yeah, Dr. Crow, we can. And then we have a question from Dr. Turner too, but go ahead, Dr. Crow.
So my question was in the beginning, you wrote like 4 or 5 reasons of why what would be the main causes to pay for medical. So in my what I'm understanding is that we're trying to make our cases fit into those 4 or 5 reasons. Is that
No,
correct?
no, 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 no. Those are the ones that are currently part of the dental exclusion right now. So any dentist without appropriate documentation or anything else can bill for those 4 domains. Medicare has approved those irrespective of anything. What we're talking about is doing surgical procedures and linking those surgical procedures to comorbidities, which all of these patients have, right? They have cardiovascular disease, they have osteoporosis, they have diabetes. That's what we're talking. So it's totally different. We're not,
Understood. Okay, I
yeah,
get
we're
that
not
now.
putting that. That's the stuff that's existing and approved and
Understood.
has been. Yeah.
So what is the percentage that this happens, that I get a patient that comes in for a consult, I tell them this is kind of how much you can expect to get off from
Yeah.
Medicare. I do the procedure because it's not commercial insurance, it's
Yep.
federal. And
Yep.
and what is the percentage that comes through versus that I'm stuck holding the bag?
98%.
So your software, your notes, everything
Yep.
that you've got is going to
Yep.
get me to 98%.
Yep.
Okay.
Yeah. Yeah, I mean the feds. The reality is Medicare pays. It's certainly more predictable than commercial insurance, where you have to jump through a bunch of hoops. And that's why I said, going down the commercial road is much trickier. And again, a lot of people think about, well, I don't want to do this because I'm afraid of fraud and going to jail. There are people who've been billing. There are dentists with no MD who have been billing Medicare for a long, long, long time. I mean, I've been doing it since 1996. And again, it's all about demonstrating that medical necessity, linking it to the oral issues that you're treating, having the appropriate documentation, using the right codes, etc. So there's a process. Now, the advantage of this is it takes all of that thinking away from the dentist who's not used to speaking that language, right?
Sure.
You can still speak French. We're translating it into Russian and we're submitting it to Medicare in the language that they understand.
So tell me a little bit about the 5% for audit defense and what happens there and what happens if we exhaust those funds. Do
Yeah.
we,
So
tell me
no,
a
it's a
little
good,
there.
yeah, good question. So the 22%, some people can opt out. So we've had some clients who have said, listen, I'm just going to pay the 17%. And if there's a clawback, there's a clawback. Um, I have been subject to a clawback, just, and it's one of those things. Medicare just randomly does audits. They look at it, they sample 10, 20, 30 charts. They look if things were overcoded, undercoded. They make a judgment and they say, you know what, we think we've overpaid. We want $5,000 back or $10,000 back or whatever. So what we've done in order to sort of soften that risk is allow customers to say, listen, I'm going to pay the 22%. That 5% stays in essence, a an escrow fund. And if there is a clawback, we pay it. You guys, it's not paid by the customer, it's paid by us because we're the ones doing the medical billing.
Even if it exhausts my funds of that 5%.
Correct.
Okay.
Yeah, and again, Medicare only claws back up to 3 years retro. So they'll only look after 3 years, sort of past the statute of limitations on a clawback. So they can only go back, or right now only go back 3 years.
What does it look like to the feds though, when you're a provider and you go from billing $0 and I've got the infrastructure in my office to bill, $6 million? I mean, that's got to throw up red flags. So, I mean, we're banking on you, right?
Yeah, I mean, you're not doing it. We are. You're doing the surgeries. We're doing the billing. Yes, we're using the office NPI, but we're using the clearinghouse, so they're getting a lot of the spotlight is not being shown on you as the individual because you're just. I don't mean this to sound disrespectful, but you're just one fish in a bigger pond of fish swimming along. So again, there's strength in numbers in that regard. That's another sort of byproduct of the system, and a positive in terms of risk mitigation to the individual clinician in office.
So the NPI is tied to you, and I'm the small fish beneath you.
Hey, that was a
It's
terrible analogy. My
no, it's
apologies.
true though. It's important. It's important distinction.
Yeah, I mean the risk is on us, not on the clinician. Again, we've been doing this for 13 years. And part of the reason for those of you who don't know me, I mentioned I went to Penn dental school and oral medicine. I then moved to the Medical College of Georgia as a department chair, and all of our staff, faculty did billing. We had pathologists, we had radiologists, all doing medical billing and credentialed on Medicare. And then I became the dean of the dental school at UNC Chapel Hill. Did that for 5 years, and then I had the opportunity to be a founding dean for New School. So when I decided to leave academics, I was obviously very careful in what organization I joined, and I would not have joined an organization that I felt was going to do any risk to me, to other clinicians, their reputation, or to patients. So I firmly stand by what we're doing as being legal, defensible, predictable, and actually the right thing to do by patients who can access care and access this benefit when they historically haven't been able to do it.
Dr. Turner, was your question answered in that?
We won't have one or two questions. We'll have a plethora of questions. So my question is who, when we contact my office manager, just did the scan up there. We're very interested in moving in this direction. I see great promise in it. Who exactly will she be talking to when she contacts your Nexus Dental Systems?
Scott,
Yeah.
could you do that?
Yep. So who will she be contacting at this number? It will be the head of our medical billing program, probably Summer Terry. But I mean, I am obviously willing to share my contact info as well, and if people want to reach out to me. But we don't have a sales team, so to speak, which is why I'm talking. I'm a terrible salesperson. But we do have experts that you'd be talking with that would walk you through the process. So Summer Terry would be talking with the billing or office manager in the office. John Poovey, who is our chief dental officer, will be talking to the lead dentist in the practice. And so there's one-on-one connections from the very beginning, when we do enrollment, to training, to launch, to monthly check-ins.
Thank you very much.
Yep.
Any other questions? Either virtually or in person for Dr. DeRossi or for Vince? Or for anybody? Any parting last words there, Dr. DeRossi?
No, I just encourage people to think about it, think about the changing demographics of disease, the changing demographics of age, and the opportunity to, do more for ourselves and our practices, but also do more for our patients. And I think this is a step in the right direction in terms of oral and medical integration and improving overall health. So I appreciate your time today, everyone, and I appreciate the invitation. And again, my apologies for not being able to get up there in person. And I am so thankful that you allowed me to do it this way.
Sure, and in the next 10 minutes after we sign off, if there are questions, are you okay with me calling your cell and helping?
Yeah, of course, absolutely. Yeah.
Awesome. All right, Jay, did you want to come up for a second here? And,
Just real quick, thank you guys, everyone, for coming out. We really appreciate it.
do you mind standing in front of the camera? Sorry.
I gotta stand in front of them. I gotta stand in front of Tiny. Guys, thank you for jumping on remotely. Thank you guys for coming in person. We're always trying to find different things to present. It's not just the same thing over and over again. And hopefully you guys find this very interesting and and has a lot of great stuff coming out, on all the social media stuff for more follow-up stuff. So just don't hesitate to call any one of ourselves if you need anything.
And if you need anybody from the dental lab side to help facilitate either Nexus, communications, we can be the liaison between that as well. Yeah, we know how to connect with them directly.
I mean, one of my questions and those, did you pick two Nexus organizations on purpose? It just makes it easier for printing and maybe.
I actually would like Jay to, he has a very good answer for that, Scott.
I mean, do you just go through the alphabet and we're on the ends now?
In all actuality, all honesty, no, it's just, I know both solutions are very, very, could play very well nice in the sandbox together, because the two most common things I talk about all next with my clinicians is, one, how do I get more patients in the chair, and get more case acceptance, and two, how do I make it faster so I have more,
Yep.
more problems.
Yep.
These exactly.
Both, and yeah, and both, I agree. Both presentations answer those two challenges quite well.
Very simple.
It wasn't
solutions.
the marketing side of it that made it easier for us. It was,
Alliteration here.
yeah, we consistently get asked questions on how to help patients in the chair and see less chair time. So Jay and I are constantly trying to figure out ways to make all that happen. So
All right.
that's where we are.
All right, thank you guys.
Thank you, Dr.
Have a
Rossi.
good night.
My pleasure. Thank you.
Dr. Bolchi, thank you, Dr. Corral. Thank you, Andrew.
Thank you. Thank you.